we'll be starting the session. The station is respiratory, and the doctor that we have here is Dr. Nandini Biswas, ma'am. She is a senior consultant, Department of Pulmonology at Manipal Hospital, Kolkata. Over to you, ma'am. Thank you.
Thank you. Okay, everybody can see the screen well.
Yes, ma'am.
Good evening. I'm Dr. Nandini Biswas, a senior respiratory consultant. And today, I hope the session helps you and it'll be a good start towards preparing for the MRCP PACES examination. And being a pulmonologist, I'll give you a synopsis of how to examine the respiratory system. Now, before I start the session, MRCP PACES clinical is actually a very practical test, and it's actually more or less a real life scenario. How you should examine the patient, how you approach the patient, how you introduce with yourself to the patient, how you behave with the patient, how you examine the patient gently but correctly with empathy, and at the same time you do it professionally as well. So it's actually a very good exam in the sense it gives you a real life feel of what you should be doing. So we'll start, and just bear in mind that the MRCP PACES is actually very much a clinical examination. So you have a communication station, then you have all the systems, you have neurology, you have abdominal examination, you have cardiology, you have respiratory examination, and of course, communication skill as well. So, of all the stations, perhaps the cardiology and respiratory are the ones where you need to do a significant bit of examination. But at the same time, if you approach it in a systematic fashion, these are perhaps the more easier stations, but you need to have a system about how you get on with it. So, respiratory, just to give you an idea, so our breathing starts from the nose and ends very much in the lower lobe of the lungs and up to the diaphragm. So, the right lung has three lobes, the left lung has two lobes, the right lung is the bigger one, the left lung is the smaller one. This is what it feels like when you examine a patient with the chest open or when you want to do any procedure or thing. So, as you can see, the right lung has three lobes, the left lung has two lobes, the left upper lobe is the bigger one. So, if you have any pathology in the left upper lobe, the whole lung seems to have moved forward. So, if the left lung has consolidation or collapse, the left lung seems to have moved forward on the chest x ray. The right lung has the big right upper lobe, then the right middle lobe, and the lower lobe. So these are the anterior views, the sideways views, and the posterior views. Very important to have an idea, because as you get on, if you do medicine, if you do respiratory medicine, you will be examining the patients, you'll be doing procedures on the patient, you'll be doing chest and pleural aspirations. So it's very important that you have an anatomical idea of what the lobes are, where they're placed as you turn the patient, you examine the patient from front, back, or from the sides. So this is your right lung, the big lung, and this is your left lung, the small lung. These are the accessory muscles which I'm going to skip. The main, the most important muscle is of course the diaphragm, and which is something we have to all bear in mind. The rest, the intercostal muscles and diaphragm are the most important muscles. The rest are all accessory muscles. So, when you examine a patient, when you're asked to do respiratory examination, so the process starts as you approach the patient, as you approach the examiner and the patient. So the examiner will give a scenario. He or she will say this is a so and so or 60-year-old or 65-year-old lady or a gentleman, male patient or a female patient. Can you please examine the patient and let us know what you think is wrong with the patient or what his problems are? So this is how the whole thing starts. So what you do first, I've given a synopsis which I'll present at the end of the presentation, and I think it's very important that you keep that in mind and you rehearse in the same manner again and again and again. So when you do the rehearsal, you do it on your friends, you do it on your patients. When you go to the ward, you do it on your friends, and you keep doing it again and again and again till the whole process, the system becomes part of you. So always place the patient at 45 degrees. Make sure that the patient is comfortable and the head end is appropriate, that there's a pillow underneath the head, or etc. etc. Very important. And as you approach the patient and as you introduce yourself to the patient, you have to notice the patient and the room. So, is the patient normal build? Is the patient overweight? Is the patient cachectic? So, so your clue to as to what the clinical problem might be starts from your observation, the patient, the bedside, the surrounding. So, is the patient cachectic? Is the patient cyanosed? Has the patient got central cyanosis? Has the patient got peripheral cyanosis? Is the patient anemic? Has the patient got pallor? Is there tar staining, or what we commonly call nicotine staining of the fingers? So as you examine the hands, see if there's any yellowish discoloration of the fingers. Look for flap. There can be fine tremor which can be related to the beta 2 agonist. There can be a flapping tremor which can be related to type 2 respiratory failure or chronic carbon dioxide retention, which is very typical of COPD. Is there clubbing of the fingers? So you should know how to examine for clubbing. Raise your hand up to the level of your eyes. Look for the angulation of the normal loss of normal angulation within the nail, a nail bed, and then join the two clubbed fingers together and see if they're far more apart than what they should be. Always examine the JVP. The JV should be examined at 45 degrees. Make sure you do that and make sure that the patient is comfortable when you look at the JVP. You should always look for enlarged cervical lymph nodes. Examination of the lymph nodes of the axillary and the inguinal region can be a bit cumbersome and bit technically difficult, not technically difficult, can might be a bit challenging given the scenario where there are people around, the examiners around, other patients around. But always look for enlarged or absence or presence of enlarged cervical lymph nodes. If you can, what matters, you may skip this, but always look for a barrel shaped chest if this is possible. It might give clue to hyperinflation or COPD. If you can, you might skip this. You might look for spinal deformities if you can. And then you look for the rate of respiration, depth of respiration. Has the patient got normal respiratory rate? Has the patient got tachypnea? Is the patient got shallow breathing or normal breathing? Very important you do that because these are the only things that you will get. You won't get anything beyond that. Types of respiration you might skip, and then you go for palpation. So your palpation starts as you touch the patient. So when you proceed towards the patient, you wash your hands or clean your hands, you introduce yourself to the patient, check the patient's name and ask permission at the same time. Is it okay? I'm such and such doctor. Is it okay if I examine you? So that is how you start. And as you approach the patient, hold the hands and start with the pulse, and then the rest follows. The palpation starts straight away. So amongst the palpation, I'll go through this again. I'll go through this within a stepwise fashion. Don't forget to palpate for the apex beat and the tracheal position. Very, very important.